Hi, my name is Beth, one of the anaesthetic reggers. Now, today I'm going to talk to you about ECGs. So I'm going to keep this really brief, really simple, because I know in your capacity as a midwife, you're not expected to be able to interpret ECGs, but I think having some awareness about them could be useful in everyday practice. So we're going to cover what is an ECG, what is it looking at, the indications for an ECG, so when it might be a good idea to do one, the very simple basics of an ECG, and then just some concerning features of an ECG that's going to make us want to get attention or help pretty quickly. And then I will conclude. So, whistle stop tour of ECGs. So, an ECG simply measures the electrical signals at the skin that correspond with the cells of the heart. Now, the really good thing about an ECG, because the heart is a 3D structure, by having multiple leads, you get to look at it from lots of different angles. So that is why it's called a 12-lead ECG. So what are the indications for an ECG? So essentially, anything cardiac, or anything that makes you think that something could be going on with the heart, or perhaps even like a blood clot in the lungs. So some classic symptoms where you would always do an ECG are something like breathlessness, because although we think lungs cause breathlessness, it can sometimes be something cardiac in origin. Of course, chest pain, or if a patient has a slow or fast heart rate, it can be a useful indication to see, is the heart just going fast, or is it going fast because there's something else going on? Then palpitations, so an abnormal feeling within the chest. Lots of people describe palpitations in lots of different ways, so just be mindful of that. And then, of course, a reason to always do an ECG is sort of someone feeling dizzy or faint, or if they've had a collapse. In fact, I would say a collapse is a very concerning feature, and you absolutely should do an ECG unless you're in a resus situation. So to try and show you an ECG, I've done a sort of embroidery of what a normal ECG should look like. Now, this is what a normal ECG should look like. And we look at the waves, so we name them with letters. So our P wave is the first little wave, and that is the top of the heart contracting. Then we have the QRS bit, so the spiky bit that goes up and then down, and that is the ventricle contracting. And then you've got the T wave where the heart kind of goes back into its normal state. So does that make sense? You've got the PQRS and T waves, and they should, in a normal situation, look like this. And you want a heart rate of somewhere between probably 60 and 100. But obviously everyone is slightly different. And the way to do this and to work out what the heart rate is on an ECG is you will have a strip, and a strip is 10 seconds. So you can count the number of peaks and times that by 6, and that will give you the heart rate on the ECG. Or you can look at the top corner and it will tell you. But it's always nice to be able to work it out yourself, I think. So I've put together a brief sort of way to interpret a ECG, and I always think being systematic and doing the same thing every time is the best way, and it means that you're not going to miss something blindingly obvious. So the first thing I always look at is the rate. So you can either look at the top and see what the heart rate is on that, or you can work it out yourself. And you want to know if the patient is tachycardic, so a high heart rate, or bradycardic, a low heart rate. And then you might escalate off the top of that. Then the second thing I do is look to see if it's regular. So does every tall peak of the QRS have a P wave before it? That's really important because you want a P wave and then your QRS complex and then your T wave. So you want to check that P waves are present. If they're not present, it might signal an arrhythmia, which you're going to want to escalate because we need to treat it. So then, does it look abnormal? So what I mean by this is we've seen what a normal waveform looks like. So you have your P, QRS and T wave. Now, if this becomes really widened, that is a concerning feature. Or if it's completely irregular, or it just doesn't look like our initial normal ECG, then we should escalate that. So The most important thing is to also remember, why is this ECG being done? Because if you've got a very abnormal looking ECG in a patient that's presented with a collapse, that is very concerning. Whereas if you've got a patient that has had 1 or 2 palpitations and you've done an ECG and it looks pretty much what you expect, that is less concerning. You're still going to escalate it and you're still going to ask a doctor to read the ECG, but they're different categories of sort of risk, aren't they? So I've tried to draw out some very concerning features seen on ECG. So the first 2 are asystole, and what I'm trying to point out here is, if a patient's heart isn't beating, in my head I expect to see a completely straight flat line, but actually that's not potentially true. You might see a few sort of small waves, but that is asystole and you need to be starting resus if that's the case. Then, to highlight another concerning arrhythmia, but potentially patients can be awake with this, is ventricular tachycardia, and it kind of looks like saw teeth or sort of shark's teeth, sort of very triangular and very regular, but widened. And you can see that you can't see any P waves there or T waves. Does that make sense? And then the third thing I've shown here, or tried to show, is something called ST elevation. So where the S wave should be is raised. So we call it ST elevation, and you can't see a T wave. Now, what this shows is the heart is being starved of oxygen in that area of the heart, and this needs to be treated as an emergency. Now, it's uncommon in pregnant women, but it is something that you should be aware of. And if your ECG machine tries to interpret it, it would say at the top, acute myocardial infarction. So I've tried to keep the conclusion really brief, and it should be a really quick way to sort of interpret the basics of an ECG. But essentially, an ECG is just a really quick way to assess the heart. And when reading it, we need to think, what is the rate? Is it regular? And is there anything on it that looks odd or peculiar that we need to escalate now? Thank you.